So pernicious anemia is a subset of B12. It's a type of B12 deficiency anemia. It's just one of the many causes of B12 deficiency. Okay. So over here we had the iron problem where we had low iron. Therefore, we had to make do with what we had, and we separated out our RBCs. We had microcytic anemias. Whereas in B12 and folate deficiency, they have to do with DNA synthesis. And to make new cells, you have to, first of all, you have to make a copy of the DNA, and you have to then go through mitosis to separate it out, right? If we don't have the building blocks, we are not going to do that. So we are going to find out we're going to have big RBCs with B12 and folate deficiency, okay? So again, we're doing iron deficiency, inflammatory is part of that, we're doing B12, sickle cell is not on here, sickle cell is actually a normal cytic. All right, so B12, what happens here? So normal B12 absorption. So B12 is absorbed in the distal ileum or the terminal ileum, the very, very end of the GI tract right down here. But to get absorbed, right, it's a B vitamin, it's water soluble, right? Our fat soluble vitamins are which? A, D, E, K, right? So our B and C vitamins are water soluble, and we have to usually have a transport mechanism to bring it from the gut into the bloodstream. So the transport mechanism here is intrinsic factor. Intrinsic factor is made in the gut, sorry, in the gut, of course, but in the gastrum, in the stomach, right? So intrinsic factor is secreted by our trusty parietal cell, which also makes hydrochloric acid, right? So the hydrochloric acid will allow it, B12 to be separated from its meat source or from its extrinsic source so that it's free and on its own. And then it's like a 1-2 punch. It's going to free it up with a low pH, and then it's going to use its intrinsic factor to bind to it, and then now it's going to go for a journey of 25 feet all the way down to the terminal ileum and then get absorbed, right? So if our parietal cells are not working, hydrochloric acid is not there, or we have antibodies against our parietal cell, which is pernicious anemia, then we're going to have a lack of B12, right? So extrinsic factor is B12. The science name is cobalamin, right? When you give B12 as a shot, it's called cyanocobalamin, right? So it's bound to animal proteins, and we have to free it from those animal proteins with the help of what? Of hydrochloric acid, right? So we free it from that, and then we now need intrinsic factors to then capture that freed B12 and then absorb it in the distal ileum, right? So the terminal ileum, all right? So parietal cells can be attacked, right? And the intrinsic factor itself can be attacked. You can form antibodies against it. That's called pernicious anemia. That's rare. It's usually a situation where you're not able to absorb B12, or you have B12 deficiency because you didn't intake enough of it, right? Or you used it, you're using way too much B12 because you have parasites, right? Like a tapeworm, sometimes pregnancy. All right, so those are usually the common reasons for a B12 deficiency anemia. And it takes like 3 to 5 years for this to happen. It takes a while, okay? Compared to like iron deficiency and folate deficiency, it takes like 3 months, right? This takes about 3 years for you to develop B12 deficiency anemia. All right, if you resect part of the GI tract, this part of the GI, of the gastrum is what secretes the intrinsic factor the most, has the most parietal cells, has the most hydrochloric acid. But when we have weight loss surgery, what do we take out? That piece, right? So you're going to have problems, right? If you have a gastrectomy, you have to make sure you take your B12 shots or B12 supplements. But everything nowadays has B12, right? For instance, that this Rockstar has B12 in it, and the Gatorade has B12. Every cereal you intake has B12 as well. This has, what does it have? It has 100% my B12 for today, right? So it has all the things. All right, chronic alcohol use is going to impair our stomach, but also impair the storage of B12, because B12 is stored primarily in the liver, okay? And then Crohn's disease, that's going to affect the what? The terminal ileum. All right, therefore, we're going to have lack of B12 absorption. You might have the intrinsic factor, right? You have the gas, you have the hydrochloric acid, you have the intrinsic factor, you have the B12. They're ready for their Vienna siesta, or Vienna, what's it called? Not moped. What's the word I'm looking for? Vespa, right? They have their Vespa, right? They're all the way down to the terminal ileum. So you got to see it's great, beautiful views, right? And they get there and it's closed for business, right? It actually has skip lesions. It had a cobblestone appearance. It looked great on the way in, but then I guess they fell into a fistula, and then I don't know. So they had that's going to cause a lack of B12 absorption, right? Celiac disease is the whole GI tract is affected. With celiac, you'll learn about that more in peds. And then gastric acid. You don't secrete the gastric acid because A, you have gastric cancer or achlorhydria or H. pylori, or you're doing it, right? You're taking PPIs or H2RAs. Then your intrinsic factor is not going to work great. If you look at your PPI and your IV push checkoffs and have your PPI side effects was anemia, right? B12 deficiency anemia, right? What else? So increased B12 use, we mentioned that, and then inadequate intake. So they have low socioeconomic status, long-term vegetarian, vegan, without B12 supplementation, but it's kind of hard. You have to really go around every possible way to not get B12 in your body, right? Usually nowadays, if you take any kind of multivitamin, you're going to have plenty, all right? But everything nowadays is fortified, right? It's the law for folic acid. For B12, I think they just do it just because, right? Because they can advertise. All right, so what else? So we need the parietal cells that will secrete what do they secrete? HCl and intrinsic factors. So they can then go for a ride, right? You need the HCl, you got intrinsic factor, and you need to actually have B12 there, right? To dislodge from its protein source, right? And then it goes all the way to the terminal ileum and then gets absorbed. All right, so B12 functions. What does B12 do? So B12, we know it makes RBCs, but it also is involved specifically in the formation of DNA, right? So you have B12 deficiency anemia, you're going to have a lack of DNA production, and RNA for that matter, right? It specifically is responsible for making the, I think it's thymine, right? Which is one of your base pairs in DNA and RNA. So if you don't have that, you can't make the integral ingredient for our DNA and RNA. Therefore, we can't function well. Okay, so B12 is an essential cofactor. So what's a cofactor? Just kind of like magnesium is a cofactor. It's like the key to many proteins in the whole body. B12 is also a cofactor. It's going to be the key to make sure that you can work on specific enzymes work on specific substrates. Technically, it like activates enzymes. It activates things, especially in the CNS and also in the bone marrow, so that we can have an adequate function, right? So it works hand in hand with folic acid, and we'll talk about folic acid also, right? So folic acid is technically, its active form is 5-Mother-F, right? So that's the active form, right? And that's the start of purines, right? So you have purines and pyrimidines. You have pure as gold and pi cut. Remember this back from science, 4th grade science, 6th grade science, college science, all the different purines and ATGC and base pairs. It's all coming back together now, right? This is what B12 and folate is responsible for producing, all these little nucleotide base pairs, right? It also converts homocysteine into methionine. So methionine is right down here. You got the little methionine is broken down, and it will then make its energy. Remember glycolysis, our favorite cell respiration cycle, glycolysis and Krebs cycle. So here's the Krebs cycle right here, the citric acid cycle. And B12 is an entry point to that cycle. And it converts the homocysteine into methionine. Why is that important? Because if you don't do that, homocysteine builds up. You don't have B12 right here to convert that homocysteine and break it down. Homocysteine builds up, and homocysteine is indicated in like pretty much every cardiovascular disease and cancer and such. All right, so homocysteine elevations, I think I put over here, not on the other slide. So increased homocysteine. This also happens with B9 sometimes, but that's going to cause autoimmune diseases. That's going to cause breast, cervical, and lung cancer. It's going to cause cardiovascular disease, ASCVD, MI, strokes, osteoporosis, which is pretty bad, right? So that's also something we want to make sure we avoid and have adequate B12. Okay. So one of the things that B12 also does is an integral in making neurotransmitters. So if we don't have neurotransmitters, we're going to lose nerve function. So one of our symptoms is paresthesias in the legs, especially. Our nerves don't work good in the legs, and it's a permanent loss of nerve function, right? And then also they have like a dementia-like symptoms. They have forgetfulness, memory issues. So all these things result because we lack the DNA, RNA to make them, but also directly it's responsible for making serotonin, melatonin, dopamine, and other adrenergic things like norepinephrine. Okay, so we talked about the ATP things, right? It converts methylmalonic acid into succinyl-CoA. So that's one of the things it does to help this process, right? It to make energy. So without that, you have a buildup of bad things, right? So the B12 and folate are all interrelated. So 5 in mother F, that's the one that's right here. 5 mother F is right. Where is he at? He's not the mother F for enzyme. He's the, where's he at? 5 mother F. I think he's, I'll point him out later. I think he's not right there. But methionine is somewhere, I can't picture on this one. But anyways, these are all integral to the formation of DNA and RNA. And when you have RNA, you can make proteins, right? You have normal functions. All right, so decreased B12, you have increased MMA or methylmalonic acid. The reason why I bring it up is because that's one of the tests you do. All right, so MMA over here, you can see, is converted into succinyl-CoA. Succinyl-CoA is part of the citric acid cycle. I think I misspoke about the homocysteine earlier, but homocysteine still builds up, but this is a different process. All right, so methylmalonic acid will build up when you don't have B12. B12 is integral to converting that, right? If you don't have that, MMA builds up, and that's one of your key things that tells you someone has B12 deficiency anemia is when MMA is elevated. All right, so that's over here. It's not pictured on this one, but here's a neurotransmitter piece. All right, and then B12 is integral with 5 mother F, right? And that then gets recycled, and we can utilize our folic acid, right? So folic acid and B12 have a lot of overlapping symptoms. It's just that B12 leans a lot more heavy on the neurotransmitter piece, has a lot more neurological signs. Okay, what else? So you can't form myelin sheaths, you can't form neurotransmitters. All right, you have the homocysteine elevation, and also the RBCs, like I mentioned at the beginning here, they can't divide as much as they like to. So since they can't divide, every time they divide, you have less tissue or less cytoplasm each time, and you get a average size RBC. Well, if you can't divide, you're gonna have all that cytoplasm, you're gonna have a big RBC. You're gonna have what's called a megaloblastic big RBC. Okay, so we have the homocysteine to methionine process gets abruptly stopped with folate deficiency and B12 deficiency. So those go up, and we get all these bad consequences of elevated homocysteine, which is a test you can run if someone has ASCVD, if someone has an MI, or has a history of CAD, stroke, et cetera. That's something you can run. So, oh, the reason why you have this might be because of your anemic state. Okay, and we have a macrocytic anemia because the cells can't divide. They don't have the DNA and RNA pieces to finish the RBC production. All right, so B12 anemia symptoms and diagnostic tests. So we mentioned MMA is going to be on there. MMA is increased because it stops. Right? B12 is an integral piece to this assembly line, and you can't convert that into what's needed, right? So MMA goes up, right? And you can measure it in urine or blood, and that's what differentiates it from folic acid deficiency. So MMA will be increased in B12, but not in folate. So here's MMA over here, right? And then we got symptoms of B12 as all the symptoms of anemia, which are what? Dyspnea exertion. They got SNS symptoms. They got they're syncopal. They have SNS response. I said that already, right? Tachypnea, tachycardia, diaphoresis, etc. But they also have irreversible symptoms, which are because of the demyelination. In the spinal cord specifically, it's kind of where it hangs out, and it starts causing the legs to have a lot of paresthesias, right? So peripheral neuropathy, paresthesias. Ataxia. What's ataxia? It's an unstable gait, right? So they can't do what they intend, right? They got visual disturbances. The eyes can start shutting down. They have ear disturbances. They have tinnitus and balance issues. So, and also impaired taste. And when you say someone has impaired taste, you say they have dysgeusia. All right, so dysgeusia is impaired taste. And then psychiatric symptoms, because remember it's involved all the neurotransmitters. They're going to have depression, mood swings, dementia-like symptoms, mental fog, altered mental status. All these things happen with B12, right? A lot more than folate. Folate can have some neuro symptoms, but usually folate just has like the generic anemia symptoms. Okay, and then we have megaloblastic cells. Well, megaloblastic sounds like macrocytic. What is the difference? So megaloblasts, so remember you need DNA and RNA, and we can't make DNA and RNA, so they don't divide completely. So the nuclei are multilobar. they have a whole bunch of lobes. They look all odd shaped, right? So it's a multi-lobar macrocytic anemia. All right, so what else? So CBC, got a low H&H, that makes sense. They have anemia, right? And then because we have a macrocytic anemia, we have big RBCs, the spleen doesn't like that. The spleen wants every RBC to look the same, right? And if they don't look the same, it starts eating them. So the spleen does that. It starts eating all the big RBCs, and when it eats them, it's going to spill their contents. And what's inside of an RBC? Heme, right, and globin. And also it has LDH, lactate dehydrogenase, for lactic acid, for lactic acidosis. So that's one of the tests we can do. If someone's hemolyzing, we can look at the LDH level, right, lactate dehydrogenase, right? LDH marker is indicative of a spilling of cell contents, right? So here the cell in question is the RBC. Back in the 60s, before troponins, they looked at that for myocardial infarction. It's like, oh, your LDH is elevated. You must be spilling LDH from somewhere. And that somewhere must be your heart tissue. All right, so LDH is inside of every living tissue. And we can say it's probably the RBCs if the bilirubin is going up or down. Up, because that means more heme is being broken down, right? And then haptoglobin. What's haptoglobin again? It's like the Velcro that's going to bind all the extra heme that's floating through the body. And it's going to be bound, therefore it's going to be low. So low haptoglobin, elevated LDH, elevated bilirubin, these are all signs of hemolysis. The reason I bring it up here is because like sickle cell disease has hemolysis, some of the leukemias have hemolysis, some of the chemotherapies have hemolysis. So these are all symptoms or actually diagnostic tests that will tell you someone's hemolyzing in front of you. Okay? Obviously, if you give the wrong ABO PRBC, they'll get hemolysis also and have the same labs as their antibodies start attacking all the RBCs that are incoming and spilling them into the bloodstream. So mean corpuscular volume, that's the average size of the corpuscles, right? So are they going to be big or small? What are they in B12 deficiency? They're big, so they're 80 to 100 is normal, so greater than 100. Or they got big cells, and the cell size is big compared to the other ones, so therefore everything's not normal, or everything's not the same. So the distribution of width between all the RBCs is wide, right, statistically. All right, so what else? So cell division is the important piece here over the beginning here. We talked about the iron piece before with iron deficiency anemia, where you start making hemoglobin with iron, but really we are unable to divide, right? It kind of gets stopped halfway through, and therefore we have big cells, right? Because you start with an RBC and you're going to then parse it out, okay? So what else? So B12 assays, meaning that B12 tests you can do. So we talked about MMA is one test you can do. Homocysteine will be elevated in both B12 and folate. The only difference is which one. The MMA will tell you the difference between B12 and B9. Okay, and you can measure B12 levels, but that can be false. It is not always great because it can vary, and they might have poor B12. There's other reasons why your B12 might be low. Okay, what else? So intrinsic factor. So the only reason why you'd be doing intrinsic factor tests is if you suspect something autoimmune. So they have antibodies against their intrinsic factor or antibodies against their parietal cells. That might be the reason for their their B12 deficiency anemia. Okay. The other piece, like we mentioned, where RBCs are big. So as they are trying to squeeze out the bone marrow, they kind of look like this. Or they're trying to squeeze out, and they get teardrop shaped. So one of the unique things on a peripheral smear, or when you look at a CBC with differential, right? You have CBCs and you have CBCs with differentials. What's the difference? One costs more. What's the other difference? Why does it cost more? You have to hire somebody to take the sample, put it on a slide, put it under a microscope, and look at it, right? And they look at it and they do a little count of all the RBCs, all the white blood cells. Well, nowadays the machine counts those things. But what the machine can't do is count how many teardropped shape, or is there teardrop things? Is there, weird looking things, sickle cells and such, right? A lot of computer algorithms can nowadays, but that's kind of where we're at right now. Okay, so we can look to see that they are teardrop shaped because they're huge. They're trying to squeeze out of the bone marrow. As they squeeze out these huge fat RBCs, they get teardrop shape on the way out. Okay, So what else? So we mentioned B12 is important in several areas, not only for neurotransmitters, but also for the Krebs cycle, and also for this methionine cycle to break down homocysteine, right? It converts homocysteine into methionine, and then the homocysteine goes up, which is not good, and also MMA goes up in B12 deficiency. All right, so how do you fix it? What are the fixes for B12 anemia? Well, diet is a good start, right? So animal proteins, fortified foods, pretty much everything's fortified, even vegan milks, plant milks are fortified, cereals are fortified, and then we're going to promote vitamin C. Pretty much for every anemia, it's not wrong to say vitamin C. Does it do anything for sickle cell disease? No, but I'm going to, dock you for it if you tell your sickle cell disease patient, oh, you should eat some more bell peppers and guava. It's like, that's okay. That might be just a healthy recommendation. Otherwise, it's really great for iron, it's really great for B12, it's really great for B9 or folate deficiency. All right, and then here's some high B12 things: clams, tuna, crab. Those are the highest B12 things that people normally eat. And then pharmacological. So we can give B12, but if they have like an intrinsic factor situation in their gut, or the gut doesn't work, that's PO is not going to work great, right? So we might have to do IM B12, which is called cyanocobalamin, right? So they take that and it just bypasses the gut and it restores the B12. And cyanocobalamin is red, so it's a way you can recognize it on the floor. Okay. That would make sense. They should be called rojo cobalamin. All right, so folic acid deficiency or folate acid. Folate, when you say folic versus folate, it's when you combine acid into a word, it's called folate, right? So folic acid is folate, hydrochloric acid is hydrochlorate, bicarbonate, right? That's just a science, a chemistry thing. So they're kind of interchangeable. But B9 and B12 are very interrelated, right? And they have this very similar symptoms, very similar findings, except for that one lab test. The MMA will be elevated in which one? In B12, right? And how do you replenish folic acid? You have to eat foliage, right, to replace it, right? There's no situation where about tannins and polyphenols and oxalates, just eat all the green stuff you can. All right, so folic acid, all right? There's a synthetic version and a natural version. Obviously, the natural version is better, and it is water soluble. Therefore, we have to make sure it gets absorbed optimally. It doesn't need like an intrinsic factor or anything else special, or it doesn't be converted from Fe3 to Fe2 or anything fancy. And vitamin C is going to help it along, though. There's little transporters inside the gut there, right? So I had to switch these things here because I was like, wait, folate is absorbed in the jejunum. Why is it all the way down there? But I realized it said, this is absorption defect in giant schnauzers and Shar-Pays. Like that's veterinary medicine is the same as human medicine. It's just a little bit of difference. So, anyways, it still works, right? I just swapped the key and it works great. All right, so you absorb folate, right? In the jejunum, iron is located where? Iron is in the duodenum, a little bit of jejunum, and the terminal ileum. Again, I had to switch it because in dogs it's actually reversed, but it's what is it? Our B12 is absorbed in the terminal ileum, right? Cobalamin or B12 is absorbed all the way down there in the terminal ileum. Okay, so 40% of our folate is stored in the liver, and it lasts for about 3 months, and then after that we have to replace it. If we have decreased intake, that's going to be a reason for folic acid deficiency. And that could be poor socioeconomic status. There's food deserts out there where all they have is a convenience store, and they can't get any foliage there, right? Malnutrition, also the convenience store, you get alcohol, and that's going to not help with our folic acid. Elderly they don't have the funds, they can't leave their assisted living place to get the things they need to intake enough folic acid, right? There can be decreased absorption. We can have a jejunum problem, we can have a Shar-Pei problem, right? We have Crohn's, we have celiac, ETUH competes with folate. So that could be a problem. We bypass the jejunum, like in a Whipple procedure, or as those Roux-en-Y procedures, bypass the jejunum, go directly to the ileum. That could be an issue, so those guys need supplements, right? And then folic acid demand. So we have increased demand because we have pregnancy. We're hemolyzing and we're breaking down RBCs left and right. We need to get in an increased intake to accommodate for that. And pharmacological antagonism. We already talked about E2H antagonizing folic acid. Methotrexate we'll mention with chemo as well. Methotrexate is going to be it's an antifolate, right? And also, what's another antibiotic that's antifolate that you've been vigorously studying? Yeah, inhibits folate production and therefore inhibits DNA, RNA production. No? Aminoglycosides work in the ribosome, don't they?
Oh, it's Bactrim.
Bactrim, right? TMP-SMX, all right? So Bactrim, that is antifolate. Kind of like methotrexate, it's also antifolate. Those are our two popular antifolate meds, right? Methotrexate is going to stop the folic acid production, and it stops cancer cells. It's a chemotherapy drug, but we need to actually give our cells what's called leucovorin, which is a folinic acid. It's called B9, or sorry, of course it's B9, but folinic acid, right? And it's actually our normal cells can use folinic acid to restart the cycle, whereas we stop the cycle halfway through for DNA RNA production with methotrexate. We'll talk about more about methotrexate with chemo. All right, metformin actually antagonizes B12. Oral contraceptives, other chemotherapies, we mentioned methotrexate. These guys are going to be antagonizing folate absorption. And then chronic illness. We've got dialysis patients. They don't dialysis itself you can pull out folic acid that's floating in the bloodstream. All right, so what else? So the active form of folic acid, right? You can have folic acid or intake folate, but essentially it's going to get converted in the gut and into 5-MTHF, mother F, right? 5-methyl tetrahydrofolate, right? That's going to be the one of its final forms, right? It's not even its final one. It will then eventually convert down and be converted into a big cycle, like we pointed out before, and it will then eventually make DNA and RNA, right? So here's where I was talking about. So you got 5-mother F right over here. That's its active form that's circulating in the bloodstream that we can just pick up and use, right? And we used our mother F enzyme, that was my favorite enzyme right there, to convert it into 5-mother F. And that's going to then do its thing and eventually lead us to, there's my enzyme. And then it's going to lead into DNA, RNA production, right? So we have nucleic acid synthesis. That's our DNA and our RNA, right? And in this cycle right here, we mentioned methionine gets converted into homocysteine and vice versa. And we want to break down homocysteine, otherwise we get all the bad side effects such as coronary artery disease, stroke, cancers, etc. So homocysteine will be elevated when we don't have folic acid. Same thing with B12. You can see B12 is integral to this whole process as well, right? We're just talking about the folate angle right now. So what's elevated in both B12 and folate deficiency is homocysteine, right? But MMA is not. So you can see here, MMA just works just fine. So it's normal in B9 deficiency and folate deficiency. Okay, so without folate, we don't have the building blocks for our DNA RNA, so specifically the base pairs, right, which is your ATGC, right, base pairs. We mentioned some of this with HIV. HIV meds they look like ATG or C, and that will fool the virus and stop the virus from replicating itself, right? So it's kind of a similar thing how some therapies will inhibit this as well. One of our chemotherapies, methotrexate, inhibits this production, specifically of the purines, I believe, and that's going to cause a lack of DNA and RNA, specifically for our cancer cells that are dividing super rapidly. Okay, so we got pure as gold, AG, and we got pi cut as our cytosine, uracil, and thiamine. So that all these things can get inhibited with folic acid deficiencies. Okay, so thiamine, did I say that right? Anyways, we got, we talked about B12, we'll have elevated, which one? Which one's elevated with B12? MMA, right? It's just normal in folic acid. That's the difference and is the reason why, right? So one of the processes here is that it methylates something, right? It adds a little CH3 group, and then once you have that, then you can have thiamine, which is our guy right here, right? So I misspoke. It's actually a pyrimidine, not a purine. But anyways, you can't make thiamine if you don't have folate, right? And that's what all these sequential steps eventually lead up to. Okay. So Dynos tests are the same, except for we have a normal serum MMA. The hemoglobin hematocrit is going to be low, right? The mean corpuscular volume is going to be increased because we can't make DNA and RNA, so the process kind of stops here or slows down. We can't divide as much as we want, so since we didn't divide much, we're going to be fatter. If we divided a lot, we would be thinner, right? We would be normal sized. But if we can't divide much, we're going to have a macrocytic anemia. Okay. Also, it can't divide; it gets stuck, so it also gets megaloblastic. Has nuclei that are very lobular and easy to see on a peripheral smear that you hire a lab tech or lab specialist to look at when you order a CBC with differential. Okay, so again, just like with B12 deficiency, the spleen is going to chew on these big macrocytic cells, these huge cells. So you're going to have the same things you had with B12, right? You have the bilirubin elevation because you're breaking down, open those RBCs. Inside the RBC is hemoglobin. Inside the RBC is LDH. And the hemoglobin gets sopped up by haptoglobin, therefore it is lower. And look, you get some jaundice as well. Okay. And then you think, usually when you break down RBCs, the reticulocytes are ready to go, right? They're going to be called to war. They're going to be drafted and then pulled into circulation. But here you can't make reticulocytes as you could, such like in sickle cell disease. In sickle cell disease, those guys are ready to go, right? But here, they're going to also be low, all right? We can measure folate levels, and really it's the MMA and homocysteine that's going to really let us know if someone has folate deficiency or B12 deficiency, right? So you can see the little tear icons that show some people who are folic acid deficiency, right? That's what you see when people on the street. They go to Walmart and they got the little tear. Oh, you must have folate deficiency. Let me check your pupils. You have pale conjunctiva. It's not. FY. All right. So treatment for folic acid. How do you fix it? Well, diet is a good start, right? Increase the diet because you have 3 months worth that you lost somehow. So we have to make sure we are replenishing that if possible. All right, if they're able to. Remember, folic acid is due to a deficiency in foliage. All right, so edamame is actually the highest folic acid content. All right, we got asparagus and spinach. All these things are foliage. We need to replenish our folic acid deficiency. Okay, we can do PO, and of course, you're going to recommend vitamin C. You do vitamin C also with your edamame. So edamame with like stuffed bell peppers. I don't know. All right, so you're going to have, and then crushed in, what is this, lentils? All right, the little dal soup. Okay, so we're going to make sure that we are increasing our folic acid consumption. All right, so what else? So sometimes people are not mother effers, so you need to then provide a direct supplementation of the active form. If you talk to any nutritionist, they're going to recommend all kinds of different versions of it. Folinic acid is usually only used for methotrexate, right? But there are other active forms, like the best form that's natural is from the foliage, right? The folate, and the folic acid is usually found in supplements. So it's, you have to get it in your body somehow. And of course, we're going to look at symptoms, and we can do lab tests to see if it's working or not working. Okay, so vitamin C is great to help absorb folic acid.